The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flight Bridge Ed in their entirety.
Welcome to the final episode of the Fast Archives miniseries. This last talk is from our very own Chris Meeks, titled Oxygenation Assassin. In this episode, Chris unpacks how we should be approaching hypoplastic left heart syndrome. He'll walk us through the key complications and what effective care looks like in these rare cases, emphasizing that the outcomes we affect for these patients isn't made in the moments surrounding the emergency. It's in the hours spent learning, recognizing, and understanding the small percentage cases. It's been great to curate and share this mini-series with you, and if you're craving more, head over to fbefast.com to see how you can join us in person for more great talks like this one at Fast 24. Now let's get started learning from Chris about making a real difference in patients' lives. Enjoy the episode, and I hope to see you soon.
You ever seen The Office TV show? You remember the wedding when Michael comes up with 6 or 7 opening lines for his speech? It's kind of how I felt about this talk. I'm honored to say this is my 3rd time on the Flight Bridge Ed stage, and much like Sarah Call said today, I still question why I'm here. And when I discovered that I was far more nervous about this talk than I have ever been about a talk, I had a moment where I realized that I think for the first time in my career, giving a speech isn't because I'm wanting to check off a box on my own accomplishments. It isn't because I'm wanting to share something that I've become really passionate about. What I've discovered is that this talk is about a population of people that are widely underserved in the pre-hospital and transport community. This group of people are patients with congenital heart defects. These congenital heart defects, 1 in 1,000 babies born every day will have a congenital heart defect. 1% of the world population has some form of congenital heart defect. Now, those numbers are skewed widely depending on which data source you're seeking. But across the range, what you start to identify is that these kids exist, though we tend to forget. Why do we forget about a sick child? I'm going to ask you what brought you here this week. Some of you, it may have been an excuse to get a company-paid trip to do some gambling. Anybody gamble this week? Don't be shy. I won't tell your family. Okay. I am surprised that not many hands went up, but I do respect the lifestyle choice. When we look at the population of congenital heart defects, we find that there's a subset, and that's the cyanotic, or even further classified, acute or high mortality congenital heart defects. That makes up 0.16 to 0.36% of the world population. So statistically speaking, you are unlikely to encounter one of these specific patients, the hypoplastic left heart. The hypoplastic left heart is the defect I've chosen to speak on today because it is, by and large, one of the more complex patients to manage, and it is 3 patients in one. But believe it or not, we find these patients more often in our career than we realize. I want to propose a hypothetical. The problem is you're dispatched to a home for a 3-day-old male. This male was discharged a little bit early from the hospital with normal aftercare instructions. Upon your arrival, you find a child in what would be textbook moderate respiratory distress. You see signs and symptoms consistent with the problem that was called and reported. Ask yourself honestly, who's going to give oxygen to this patient? The majority of us. In fact, I'll say to clarify throughout my entire talk, by no means am I ever encouraging you to withhold oxygen from a patient because you're afraid of a low percentage possibility. But with the thought process in mind that critical care is critical thinking, it's not the skills, it's not the classes, but it's the knowledge that allows us to customize our care for the human being sitting in front of us. We respond the way we were trained, but during your transport, the child's heart rate begins to decline. They were moderately tachycardic to begin with. You've got a non-rebreather on the patient. You recognize some respiratory fatigue, so maybe you consider non-invasive positive pressure ventilation, and you start going down the rabbit hole of resuscitation. The majority of us have been here. The problem is this kid's SpO2 doesn't seem to improve, but they seem to get worse. They become bradycardic and they code. We run through all of our normal procedures and we're left asking the question, what happened? Did we miss something? Did we do something wrong? Do we just call it SIDS and move on with our life? Our responsibility in healthcare is to two people. The human being on your cot in front of you, and to the human being that will be there next. So what can we learn from this semi-vague, unlikely to interpret, unlikely to even see it, patient presentation? Now I have to ask you to go and equip and train your staff for a call that less than one of them over the next decade is likely to run. Are you going to spend money on 0.16% of your population? I was speaking with the mother. She came in to ask some questions about our EMS agency, and they were fairly pointed. She said, how come kids like my son aren't taught in paramedic school? I said, I suppose it's because it doesn't happen very often, and I need to prioritize the education to the patients that we're going to see. I probably could have answered it better. She looked me dead in the eye, and she's the sweetest woman. She is a big part of this talk, and I'll tell you all about them. She said, Chris, what you're saying to me is that because my son was born with a congenital heart defect, he deserves less medicine than the other kid because he's not normal. And this shook me to my core because what it showed me is that there's a population of patients that I am potentially seeing. If you want to argue about statistics, this is 0.25%, but I spoke with a pit boss downstairs last night. I did a lot of interviewing of people for this, and he told me that the average probability of hitting a jackpot in one of the casinos in Las Vegas is 1 in roughly a couple million. We did some math, and I punched it out, and it's about 0.000367%. So if you gambled, you're already accepting odds lower than you are to see this. So let's prepare. What happened? The patent ductus arteriosus is the first opportunity to talk about congenital heart defects. It's one of the most common congenital heart defects by itself, but we are isolating cyanotic heart defects. Now remember, the function of the PDA, the patent ductus arteriosus, is to bypass the fetal lungs while undergoing maternal circulation. Portions of this pressure go to fetal lung development. The remaining pressure is transferred into the aorta and distributed across the body. Another reason for this is it allows for the mixture of oxygenated and deoxygenated blood, a core piece of fetal circulation. The stimulus for the closure of the PDA is oxygen. When a child takes its first breath at life, this change in interthoracic pressure and interpulmonary pressures stimulates a shift in the pulmonary blood pressure and an increase in the oxygen tension within the arterial blood, which causes a vasoconstrictive reaction inside the walls of the PDA. And over the first several hours and several days, this PDA will begin to narrow till it's completely closed and will eventually seal itself off and go away. There are cases where you can make it to an adult with an undiagnosed PDA and be perfectly fine. The PDA becomes the key to understanding how we save these kids' lives. The PDA is how we're going to kill these children. And it's because we have one medication on our truck. It's the secret assassin. You see, oxygen sneaks up on us. It doesn't scare us. It's a sneaky assassin because it's the thing that you're closest to that's going to bite you the hardest. We see a hypoxic child. We rely on our training. We use the medications and equipment we were taught to, and we still did harm. Well, we can't undo a century-old collection of data that tells us how to care and maximize out-of-hospital cardiac arrest and resuscitation in kids. I can't undo that data for 0.16%. So what's that leave us? It leaves us with a recognition that we have to understand the physiology a little bit better to critically think through this critical care call. Hypoplastic left heart is a incomplete or minimally complete left ventricle. That left ventricle is going to be minimally functioning, even if it has the ability to express some preload. In addition to this underdeveloped or non-developed left ventricle, you will have a resulting aortic stenosis or incomplete development of the aorta. Additionally, as a part of this, you have a PDA as well as an atrial septal defect. These defects are the key to this child's survival. In fact, in some cases, if the child does not have an atrial septal defect, they'll surgically create one to allow right to left oxygen exchange or a venous admixture that is going to mix oxygenated and deoxygenated blood and deliver it downstream to allow the patient to survive with such a low functioning ejection fraction, such a low functioning cardiac output. Now, for those of you that are interested in pushing your careers, there's a test called the CNPT that's very heavy on congenital heart questions. And in a cool study tip, I know it's the end of the conference, your brains are fried, and I could throw a bunch of cool stuff at you. And I thought about this. I said, how can I make the points of this talk so simple that the most tired, brilliant minds are going to be able to remember it and use it? And I broke my own rule. What I did was I created acronyms. I've got 2 of them for you, and you're going to see the theme. But I think of hypoplastic left heart as a no good flow situation. And you're going to see that NGF repeat itself. Because within the first several days to weeks of life, depending on when the hypoplastic left heart was diagnosed, you're going to undergo a Norwood procedure. A Norwood procedure is effectively connecting the right ventricle and grafting it to the aorta, so a portion of the right ventricular outflow creates systolic blood pressure and improves our cardiac output. A key point to surviving to this phase of the Norwood procedure is understanding that not only are we diluting the percentage of oxygen, negating the accuracy of our SpO2 monitors, but we're also therapeutically maintaining hypoxia. Because remember, the drive for that PDA closure is oxygen. Here's the catch. That PDA and ASD, that is allowing that child to survive. It is allowing for the increase in pressures through the cardiac vasculature to disseminate through the heart. It's allowing for that oxygen to mix. If I over-oxygenate this patient, I am likely going to cause a partial or complete closure of that PDA and initiate decompensation. Their cardiac defect may have had no connection to the original call or the original sickness. It's exacerbated by the complexities of their hemodynamics. So this is the Norwood procedure. Next, we have the Glenn procedure. 4 to 6 months is kind of the average. These kids can be discharged home. These kids actually may have been discharged home before this procedure with our modern technology and some improved practices, as well as an additional stent. There's a series that have been created to add into the first Norwood procedure if the child needs them. We're improving the survival. This Glenn procedure now takes the superior vena cava and grafts it directly on to the pulmonary artery. You still have the ASD, you still have a minimally developed left ventricle, but you have a sudden increase in preloaded flow to the lungs, to that oxygenating site. The child's SpO2 should be at or around 80%. There's going to be variables here. And in fact, I thought about putting ranges here because there's just not a lot of good research because the numbers of patients to study are still so small. We saw that about 80% with these kids is the high side of normal, and the majority of them will be given a cap somewhere in the 70s as this is where your oxygenation needs to be. This need during the Norwood and the Glenn procedure is so high that they may place the patient on less than 21% atmospheric air. They're going to remove oxygen. Naturally, this has some negative side effects. Both from the flow and the hypoxia, these kids have high risk of developing other problems, to include seizure disorders, as it's one of the more common ones. Once we've had the Glenn procedure and we survived the Glenn procedure and we are being able to show some positive response to that care, the child will qualify for the Fontan procedure. Now, the Fontan procedure is a major invasive surgery. There's nothing straightforward, simple, or easily survivable about this procedure. The alternative is a heart transplant. In fact, when you look at the clinical guidelines for the management of the diagnosis of hypoplastic left heart, you have two options: palliation or hospice. Palliative care is not something we typically think about as a solution. What you have to remember is this child will be sick every day for the rest of their life. Every day. We need these kids at or around 90%. Some will sat normally, up to 98% and beyond, and they can survive just fine with that. They may have been given medications or had a procedure to close their PDA at this point, and they're functioning fully off the ASD and the connection of now the superior vena cava to the inferior vena cava. 100% of their pulmonary flow, 100% of their preload is passively delivered to the lungs. What this creates is a profoundly preload dependent cardiogenic shock and a chronic condition. They learn to live this way. They learn to function this way. And now they're even learning to play sports this way. 15, 20 years ago, this wasn't an option. How do we come into play? Advocacy. Create programs to learn and know and understand the chronically ill kids in your response area. Right training. Advocate for the preparation and understanding. But keep it simple. Start with communication. I interviewed 6 people for this, several providers and several parents. And across the board, when I said, what is the one thing, if you could get about taking care of these patients across to pre-hospital clinicians, what would it be? And I thought they would say oxygen. And they said, forgive my language, talk to the damn parents. Here's the thing. These parents get put in school about understanding their kid's condition. They get educated by some of the top physicians in the world about that child and the relationship to that condition. They get written instructions with everything to the parts of town you can live in, the 911 agencies that are equipped to manage you, as well as pulse oximeters, respiratory monitors, everything that you can imagine that these parents will know about this child, they're probably holding in their fingertips. They may have written directives from a physician that talks about how much of what type of oxygen they can and can't receive. When their oxygen hits this level, advise EMS to provide X. See, that would be a really ideal system. To my knowledge, it doesn't exist yet. We're creating that. But if you don't stop and ask the parents, can you tell me about your child? If you don't stop to ask, they're going to tell you if they know they have a CHD, right? This kid's gone home. If they know about it, they're going to tell you. Maybe they're midway through their surgical journey. They're going to know what that kid needs. If they're not present, you're in a tough situation. So we have our next step. That's hydration. That's the H in our CHOP acronym. Hydration is key because these kids are preload dependent. In fact, dehydration for them looks like hypovolemia because they cannot tolerate any more than a few percentage and change in that preload without experiencing symptoms of hemodynamic compromise. External signs of dehydration are an early warning sign of decompensation. When a parent says, my child isn't acting right, and I'm concerned, and they have a history of hypoplastic left heart or a congenital heart defect in general, your red flags should start to go off. That's your opportunity to impact. When in doubt, hydrate these patients. Fluid balance is absolutely critical. Hydration, hydration, hydration. Talk to the parents, hydrate the patient. And then consider and critically think your way through oxygenation. Is this child oxygenating? Are they not? If the answer is no, is it a heart problem? And what is the appropriate way to fix it? If that information isn't sitting in front of you for this specific child, you can rely back on the averages, or you can ask the parents. Even when these children are delivered, it's the least amount of oxygen required that we're giving. If the target for 6 minutes post-delivery is 60% SpO2, and they are at 60%, even if they needed a non-rebreather 2 minutes ago, we take it off. The least amount of oxygen necessary. And lastly is patency. There's a medication utilized for patency of the PDA, and that's called prostaglandin, or you'll find it as PGE1. PGE1 maintains the patency of the PDA across the board of congenital heart defects and allows for that venous admixture and for that dissolution of pressures inside the heart to equalize and some form of cardiac function to take place. We must keep that PDA patent. So we restrict oxygen when indicated, and we administer prostaglandin. Typically, that's coming from a sending facility. This may be a hospital-to-hospital transfer. Where we see problems in the pre-hospital setting is the primary side effect of prostaglandin is apnea. When apnea is created as a result of prostaglandin administration, the answer is to intubate the patient. Under no circumstances do we stop giving prostaglandin because, stepping back, when we allow the PDA to close, the system begins to collapse. Communicate, hydrate, oxygenate, keep it open. So why does it matter? 0.16%, guys. Because that's Kayla's child. His name is CT. I met CT at our ambulance agency, and he walks up to me, and he gives me his big toothy grin, and he says, "Hi. My mom says you're Mr. Meeks." I said, "Yes, sir, I am. It's good to meet you. You want to see an ambulance today?" He said, "Yes, sir, but first I need to take my boner pill." I look at mom and I look at dad. Dad's about to syncopize because I think he's vagueling from trying to not explode. His mother's redder in the face than I think I was. And they turn and look at me and they say, he has to take Cialis at a very specific time every day to manage his pulmonary hypertension. And humor has become the way our family deals with things. And she glares over at the dad. 2 days later, we're at a conference event with the AHA, and we're speaking to some of these parents. And I see CT look at his little watch, gives him his pill reminder. He looks around the room, and he sees a group of adults he doesn't recognize, and he wanders over. What do you think he says? I can't say it twice, they'll get mad. CT matters. CT's dad says every day he wakes up, he recognizes and consciously thinks about the fact that if he's not intentional with his time with his son, one small thing will take his son from him. I don't have kids, but I know how I feel about my dog. Mess with my dog, I dare you. I can only imagine what these parents feel when they hear that we don't train because it's a small percentage. An unprecedented amount of time he had to wait for his Glenn procedure because of how ill he was. And they came to Kayla and they said, you have a decision to make and you need to make it soon. We either need to start making CT very comfortable or we need to start making some serious decisions. We want to offer you a lifestyle option. You can have a ill son or you can lose an ill son. What kind of option is that? So you as a provider, you have the option sitting in front of you. You have a child who you can save, or you have a child who you're going to let pass away. You see, it matters that you're here because this matters. This is a child. This is a son. This is a personality. This is a soccer player. This is best friend. This is a teacher's favorite kid. This is a dog's companion. This is potentially 80 years of impact and memory that we have the opportunity to save should that opportunity arise. So why are you here this week? Because impact matters. You set yourself apart by spending your money, taking your time, traveling across the country to spend 2 days getting your head crammed full of information, being utterly exhausted to go back and probably go right back on shift. You're here because you care. What I'm asking for is for you to care a little bit more about that micro percentage. If we can put a couple of dollars in a slot machine, we can put a couple of hours into learning about somebody's child, somebody's future. At the end of the day, this journey that we've been on together this week, this opportunity to interact with people, to curate relationships, careers, this journey that we're on, it's not ours. This talk that I'm giving, it's not mine. This is their journey. Now, I want you to think about the number of patients you've touched and the potential number of years you've added on to life. But it's not just that patient's life, it's their dad's life. It's their mother's life. It's their brothers, their sisters. It's their journey. Small percentages matter. I'm proud to say that we're standing in a room full of the small percentage. Advocate for your people. Advocate for our kids. Because together, we can do better for them. We're going to see you guys. I'll see you guys next year, I hope. Thank you.
This has been a production of the Flight Bridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.